Sorry for my accent. And we can start with the first speaker, Stefan. No, sorry, I have a problem with the app.
It's Gabriel Sterian, the first speaker with the topic about arthroscopy in the pediatric knee.
The
Thank
pleasure. Okay, so good morning and thanks for being here. I'm Gabriel Sterian. I'm a lecturer at Carol Davila University for Medicine and also pediatric orthopedic surgeon at Grigore Alexandrescu Hospital for Children. We're gonna and I'm presenting this paper on behalf of Professor Ulic, and we have a basic presentation about pediatric knee arthroscopy, just to get things started and set the frame for the session. I have no conflict of interest. So, starting from the actual title, we have three terms that we need to define: pediatric, knee, and arthroscopy, and we need to understand what all of them individually means and how they work together. So pediatric, okay, we have a specific group in the population that are really active, heavily involved in sports, with unfortunately a poor compliance to medical treatment, okay, and again they are coupled with the parents. So always when we're talking about pediatric, we have to talk about parents and the persons that are with them all the time. The knee, the pediatric knee, it's a special, distinct structure. Is not your usual adult anatomy and biology. You have all kinds of structures going on there, like physis and the cartilage, and they behave differently than the other population. So the principles that we're starting from are quite different when comparing them to the adult population. In arthroscopy, again, this was our biggest limitation for pediatric arthroscopy, and we have to thank the industry for that, because they opened the door for pediatrics. Because the biggest limitation was the joint size. Because you can't do arthroscopy in pediatrics because the joints are too small or the instruments are too big. But now we have small instruments for small joints, so then we can do, and we can try to develop this field. Okay, and we'll start with all the structures that we encounter, and of course we have the ligaments. Ligament injury is the most frequent pathology, okay, and for pediatric arthroscopy, and we're talking about especially for sports individuals like athletes or professional players. And of course the ACL is the most frequent pathology that we encounter, but this is traumatic usually, but also we have to think about congenital problems. Okay, regarding the ligaments, we have to have and we have a separate topic after this discussion about the ACL's avulsions. They're not tibial eminence fractures, but actually it's a completely different topic of ligament avulsion that necessitates a different treatment and a different approach than tibial eminence fracture and tibial tear. So it's a whole other thing. Then the meniscus, again, second most frequent pathology in pediatric arthroscopy. The most frequent pathology in younger children, younger than 10, 12 years old. And we have the traumatic lesions that we need to assess, but also have to consider congenital again. So every time we think about pediatrics, we have to think about congenital, syndromic. Okay? And this is a good example for discoid meniscus and meniscus tear. The patella, again, a very interesting topic, and the whole combination, the patellofemoral joint and the extensor mechanism. Again, of course, the most frequent one is the patellar dislocation, but having a discussion about kids. We have to address the cartilage. We might have cysts. We might have osteochondritis dissecans. You might have abnormal, like bipartite patella that need to be addressed, and we can do them arthroscopically now because we have the tools for that. Cartilage damage, again, really interesting topic. We think about traumatic cartilage damage because of dislocations, subluxations, and so on. But also we have to think about osteochondritis dissecans, and these pathologies, again, are much more suitable for arthroscopic treatment than classical open treatment that we did in the past when we didn't have the means to help them this way. Soft tissue, again, another topic for pediatric orthopedics. Okay, we have synovial problems like rheumatic synovitis, hematologic synovitis for children with hemophilia. Okay, so we can treat them now orthopedic arthroscopically. The famous plica, okay, that it's become more of a problem because people get the patients get more active and it becomes more symptomatic as they get involved in high energy sports, and of course tumors. Here you have some examples of venonodular synovitis, okay, that was treated as for a long time as idiopathic hemarthrosis. Here you have some arthrofibrosis after some knee injuries that weren't treated correctly. So a lot of soft tissue issues that we need to address, okay? And of course the extra-articular structure. So we can have arthrolysis for joint stiffness, reduced range of motions. We can do the lateral release through an arthroscopic approach now, so we avoid the scarring and the soft tissue damage that usually happens for these kids. And basically it's a complex pathology. It's a completely different and new field, and we're just starting to understand the implications of pediatric arthroscopy, and the whole range of pathology that we need to address is not just about the ACLs and the athlete and fractures. Okay, so thank you.
Thank you, Gabi, for this talk. You can now see that there are a lot of pathologies we can deal with arthroscopically. And now let's go a little bit deeper into the topics. And I will introduce the next speaker, my co-chairman, Marco Turati, who will present the arthroscopic ACL reconstruction in the pediatric patients.
Thank you to everybody. I have no disclosure about this presentation, and I'm happy that you are here to discuss about this field. So we have an increase of ACL reconstruction in pediatric patients that was observed in the last 10 years, and the reason of the increase of ACL lesions is multifactorial. Growth of children that practice sports is important, has of course the type of sport, because we have an intensive training that starts before puberty, and the problem of sport specialization in children. But we have also a more awareness of this type of pathology, and there is an increase of clinical and instrumental diagnostic capability from us. In this context, if we have an ACL in a pediatric patient that require a treatment, surgical treatment, that a point that is often stressed, considering the risk of associated lesion and the risk of possible associated lesion with a conservative treatment, which type of reconstruction we can do. We have different type of graft, autograft, allograft, but also living parental. I show you something about it. And this type of solution, quadriceps tendon, patellar tendon, hamstring, and the ETB. So how to choose? And then the situation is more complex because we can do all epiphyseal techniques, transepiphyseal or also without touching the physis with over the top and the intermeniscal ligament. So how to choose? Again, we can have extraphyseal technique like Macintosh modify, partial transphyseal, or epiphyseal like Henderson and Cardasco technique, or transepiphyseal, and then there is the topic about anterolateral reconstruction or no in children and adolescents. So again, the problem is if you want to do a reconstruction in a child, how to choose? Of course, considering age, bone age, growth potential, and patient characteristics is important. But with this presentation, I try to show you also some scientific evidence about it. The preoperative planning is essential with the bone age, but of course the MRI to consider all the associated possible lesions. And it's important also to consider any pre-existing length discrepancy or malalignment. How to treat? Of course, there is not only the reconstruction as possibility. In very young patients, we stress the importance to consider the location of the tear, because in pediatric patients, some proximal or distal tear could be repaired. But now we consider the mid-substance ACL tear that required a reconstruction. Considering this type of lesion, in literature, we have no long-term outcomes, and we have no high-quality evidence about decision-making. We are waiting for two big projects, one from US, one from Europe, the PLUT and the PAMI, to have more evidence about this topic, of course. But we have also some animal evidence. For example, if we do a bone epiphyseal tunnel, it's important to consider that bone bridge could be present if a drill hole were more than 7% of the physis surface. And moreover, considering growth disturbance, some evidence consider that all epiphyseal techniques are the techniques with more risk of lower limb discrepancies. This is strange because theoretically is a technique made for children, but if you consider the position of the tunnel, you may understand that the peripheral portion of the growth plate is a risk if the direction is not perfect. So it may be a technique that should be done with a good training. The transphyseal technique, of course, is an option. I suggest to use a single tendon, also because the other tendon may be needed for anterolateral reconstruction or for revision or for MPFL. And for the direction of the tunnel, if you do two oblique tunnel, there is a risk of the physis. But on the other hand, a two vertical one was less ideal for the anatomical function. So it's not so easy theoretically. The important point is to do a tunnel less than 9 millimeters, if possible, and to orient the tunnel to reduce in a better way the injury of perichondral ring that was the lateral portion. So if you do the graft, I recommend to do it from a transtibial portal and not from the anteromedial one, as suggested some studies, because in that way the direction was create a less growth plate disturbance. Then there are good results, as this series from our service in Grenoble. So it's a valid option. Now there is another option, that ETB technique. This technique was created by Macintosh and Darby and revisioned by the Boston children surgeons. They revised it to apply in skeletal immature patients with arthroscopic assistance and a pediatric graft fixation in the periosteum. This is the technique. We make the prelevation of the graft that was the iliotibial band, and the iliotibial band was passed, as you can see in these arthroscopic images, in over-the-top position. Then we prepare an half tunnel under the intermeniscal ligament, and then the graft was passed under the intermeniscal ligament and fixed in a standard way in the periosteum. We have a lot of options how to choose. I love this survey that was made from US colleagues. They asked to 103 surgeons that perform more than 25 pediatric ACL reconstruction per year what is the preferred treatment in patient between 8 and 50, and they suggest the technique with ETB. So I say, okay, but why for them is so important this technique? And of course, there are some studies that stress the biochemical results. Indeed, the ETB technique restore a normal symmetric and physiologic reconstruction in a growing knee, as observed by Sugimoto group in Boston. And this technique was less invasive for quadriceps and hamstrings. And why this point is important? Because the hamstring quadricep ratio is a risk factor for ACL re-injuries and for hamstring injuries in children and adolescents, not only in adults. So considering to touch or not hamstring may be a good point. Then a rupture, that is a dramatic point for our kids, because in some series is quite high, but ETB technique presented by Cocker present in a long term low rupture rate. And they don't describe lower limb discrepancies in their series. Of course, there are other options again. We have we should consider BTB in adolescent, but we are doing a systematic revision. In literature, there are not so high quality studies, only case series, but of course the return to sport was high with low rate of graft rupture and not lower limb discrepancy reported, but is for tunnel 3 and 4 when the growth plate is closing. And we have, of course, quadricep tendon that now is very recommended in adolescents. This is the results, for example, from Gagliardi, US, good results in terms of function and without so many problems. So this is a good option also for this technique. And I want just to show you all the option, because in Australia, for example, they do a transphysial reconstruction with the hamstring take from parental donor, and this point is not so is interesting from my point of view, because the graft have a predictal diameter. You don't have problem to the hamstrings of the kids, so the hamstring quadricep rupture is not touched, and then you maintain a normal biomechanical neuromuscular properties around the knee joint. They observed good results, but at 2 years of follow-up, not more, but with a great number of patients, because it's a prospective studies with 100 of patients. So in conclusion, different options are present, and please consider patient characteristics, but also your surgeon experience. ETB reconstruction is safe with a low rate of complication and re-injuries. And of course, we wait for PAMI and PLUTI study. Thank you to everybody. And okay.
Thank you, Marco,
Bye.
for this excellent overview about ACL reconstruction in pediatric patients. I would like to introduce the next speaker, the Vice President of the Romanian Society of Artroscopy, Octav Rusu, who will present us his lecture about the treatment of tibial spine avulsion fractures in pediatric patients.
Hello, everybody. It's so happy to be here. I'll start with a very, very small story about this presentation. During the last years, we do have a shift of pediatric patients in our general orthopedic hospitals where we treat adult patients. It was a great area. When should we treat under 18 years old patients or over 18-year-old patients? So this paper was made in the period that we could treat patients, minor patients in our general orthopedic hospital. And the last, I don't know, 3 patients, 4 patients were treated in a private hospital because the legislation changed and shifted, and as a debate, continuous debate about this issue in Romania. So we do have a small series of pediatric patients with avulsion of tibial spine. I don't have any conflict of interest. What are the aim of treatment is a firm reduction, a strong internal fixation, a minimal invasive procedure as possible. We do have, as I was saying, a very small series of patients, young patients with open growth palate. And I was here, and when our colleague Marco Turati presented, between 8 to 15 years old, there's a lot of different morphotypes. I mean, I've had a patient which was 14 years old, and he was 1.92 meters, with basically adult patient in 14 years old, a girl, a basketball player. And these young patients, as speaking about the morphotype, were very varied. All the patients were type 3 modified Myers and McKeever fractures. This classification was used. The mechanism of the injury, which is quite important, was direct anterior posterior with full act hyperextension in sport trauma in all cases. We did perform the physical exam when we assessed the low range of motion, decreased range of motion, the extension deficit, and pain during walking. And we were assessing these patients via radiology and MRI. We did diagnose the complete fracture of anterior tibial spine with no signs of callus formation. And we tried to assess these patients postoperatively with Tegner-Lissholm and IKDC scores with 3 and 6 months. So it's a small series of patients, a small period of follow-up. The classification we use, this classification, Myers and McKeever, modified by Zarisny. All the patients were in type 3. The inclusion criteria in this study was the age, being not like a weekend warrior by practicing sports, and no previous surgery. And the exclusion criteria was the trauma history for more than 4 weeks and patients with any type of vitamin deficits. We did AP and LL radiographs and all postoperative visits. And I think it's very important to follow up a certain protocol regarding the rehabilitation, the full weight bearing. I'm thinking nowadays that I'm more cautious in weight bearing and allowing the patients to early range of motion, full range of motions. So basically this was our rehabilitation protocols, no weight bearings the first month, and after that to 10 weeks full weight bearing. The strengthening of the quad and hamstring started slowly at 6 weeks. And the surgical technique is performed under different kinds of anesthesia with a leg holder, with tourniquet, with the 2 standard portals. Practically we did a small skin incision on the proximal anterior medial tibia. The extraarticular portion of the ACL tibial guide was secured under the tibial cortex, and 2 millimeter guide wire inserted, the axis medial to the fracture line, the medial tunnel drilled with a cannulated drill and over guide wire, and the same procedure on the lateral with camera on the AM portal. The lateral tunnel was drilled. So basically we used the standard AO procedure, which is presented on the, let's say, AO app. And after that we tried to use the sterile braided polyethylene tetrafilate suture coated with silicone, practically the fiber wire which we all have in our hospitals, and for the final reduction and fixation with the tractor file and final suture wire. The fracture was reduced with the ACL tibial guide. So basically we all know this kind of image. The first patient we treated with this technique in the AO was only this way of fixing things. So as a pros, we have 2 portals. As a cons, the tunnel may pass through fracture and might alter complete reduction. Also, we can do the management of eventual associated injuries and the common difficulty in inserting suture wire. Also, is no need for expensive implants, and the cons, it's practically you might not reach an enough reduction, and you might have a low tension in final fixation. The follow-up, we did preoperatively 3 months, 6 months follow-up with IKDC scores and Tegner and Liscombe scales. We did see the clear improvement. So basically, the discussions is a complex laxity of the ACL. The reduction and the fixation in type 2, 3, 4 fracture is always advised. It's a long discussion. You should treat it conservatively or not. There are all sorts of methods of fixation of this type of fractures. As you see, we might use the K-wires, the screws, the sutures, the suture anchors, and meniscal anchors. The ultimate strength, it's higher with 3 or number 2 fiber wire sutures than with screws with washers. It's an interesting study published in Artroscopy in 2005 by Bong and the co-workers. It's an interesting study, and also an interesting study. We found out that the suture fixation offers better resistance than screw fixation under cyclical loading. A study published also in American Journal of Sports Medicine in 2007 by Eggers and the co-workers. And there's no significant difference in outcomes regarding the type of fixation. Another interesting study published in Artroscopy by Hunter in 2004. And finally, we found out the fiber wire is stronger than anti-bond. It's practically, we are not allowed to say commercial names, but this is a study we found out published in Artroscopy in 2004, and we found it very interesting. So that's why we're using fiber wire. And in conclusions, we have to reduce and fixate this type of fractures, open or arthroscopically. We do have to restore ACL. We have to do something in all cases to lower the risk of malunion, and we have to potentially reduce the time of immobilization because we have to prevent stiffness and to minimize it. And as in all techniques, I think it's very, very important to have a proper indication and the proper patient selection, which is probably the basic, most fundamental rule in having success in doing something, the indication and the patient selection. Thank you very much. I have to run to the other room that I co-chair with my friends, Hungarian Orthopedics Society session. Thank you.
Okay, thank you, and we will discuss in another moment. But thank you so much. And so we can go with Stefan Magos to talk about deformities and outcomes after pediatric ACL reconstruction. Thank you, Stefan.
Thank you. So today my topic will be to present you the types of deformities we may encounter after pediatric ACL reconstructions and the clinical outcomes after this kind of surgery. You may know that gross disturbances are possible after this type of surgery, and the main concern would be growth arrest, although sometimes we may have gross disturbances without the presence of growth arrest. So you can see here that the risk of having this kind of gross disturbances after pediatric ACL reconstruction is low, about 2%. We can reduce the risk of having leg length discrepancies or axial deviation by performing a transphysial reconstruction, by fixating the graft far from the joint line, and by using the hamstring graft, as it is not recommended to position the bone at the level of the growth plate, as it will happen if we use the patellar tendon. And what type of deformities we have when a growth arrest happens? We may encounter the leg-leg discrepancy, where in the situation in which the lesion is situated in the center of the growth plate, or we may also encounter axial deformities in case of a lesion located at the periphery of the growth plate. And the axial deformities generated by growth arrest are represented by valgus inflection deformity when the lesion is located at the posterolateral growth plate of the distal femur, or we may encounter tibia vara in case of medial growth plate injury of the proximal tibia, or even sometimes recurvatum when the tibial tuberosity has a lesion during the surgery when reconstructing the pediatric ACL. How we can reduce the risk to have a growth arrest after reconstructing the ACL in children? It is important to think about reducing the graft diameter and also the tunnel diameter, because studies demonstrated that injuring more than 7% of the growth plate may result in having this growth arrest. Also, it is recommended to position the tunnel as central and as vertical as possible, but keeping in mind that we have to think about the anatomic reconstruction as well. It is important that the tunnel should be completely filled by the graft and the fixation done away from the joint line. There is also the possibility of having overgrowth deformities, which result due to the stimulation of the physeal growth process as a result of hypervascularization, which is present generally in young children for a limited period after the surgery. And we may have two types of deformities: leg length discrepancy as a result of symmetric overgrowth, or valgus deformity due to asymmetric overgrowth. Another type of deformity may appear as a result of growth deceleration, the so-called tenoepiphysiodesis effect, when there is a deceleration of the growth caused by excessive graft tension at the level of the physis. And as you can see, there is a study who published 2 cases of genu valgum generated by a lateral extraarticular tenodesis without demonstrating a growth plate arrest. And here are 2 studies that evaluated the incidence and the type of deformities after ACL reconstruction in pediatric patients. And you can see that there is a low risk of deformity after reconstructing the pediatric ACL if we respect the cautions we talked earlier. And now let's talk a little bit about leg length discrepancy. I put on this slide, it's very important to think about doing an exhaustive X-ray examination before the surgery, as it is important to know if this kind of leg length discrepancy was present before the surgery, or it is determined by the surgical procedure. And we may have shorter legs when there is a growth plate arrest, or we may have longer legs in case of symmetric overgrowth. Genu valgum may result as due to femoral valgus or due to tibial valgus, and it is important to bear in mind that we may reduce this kind of deformity by eliminating the causes of the postoperative genu valgum, like the implant of the level of growth plate, like the bone blocks located at the level of growth plate, the oversized tibial tunnel diameter, it is important not to injure the periphery of the femoral growth plate and also the tenoepiphyseal disease effect. The genovarum is a very rare deformity after pediatric ACL, and the tibia vara may result due to asymmetrical growth plate arrest or as a result of deceleration without growth plate arrest. Another deformity is the genorecurvatum. It is determined by anterior placement of the tibial tunnel, sometimes by the harvesting of the hamstrings graft, and the tenoepiphyseal disease defect. And now let's take a look at the literature, which present the outcomes of this type of surgery. And we have this meta-analysis published in 2013, comparing the operative to the non-operative treatment in this patient group. And it was demonstrated that after non-operative treatment, there was 33 times more likely to have a clinical instability. Patients were 12 times more likely to have a medial meniscus tear after non-operative treatment, and none of the patients in the non-operative group were able to return to the previous level of play as compared to 85% of patients in the operative group. So that's a good surgical procedure. Another study comparing 17 patients with ACL reconstruction and coexisting intra-articular damage receiving transphyseal ACL reconstruction to 14 patients without pre-existing pathology receiving a non-operative treatment, demonstrated that patients operated had better clinical result, better and functional clinical and functional results according to the IKDC Lischolm and Tegner score, and more than half of the patients treated conservatively finally got to surgical reconstruction. So the transphyseal ACL reconstruction yielded superior clinical results compared to non-operative treatment. Another study which evaluated more than 1,600 ACL reconstructions over a period of 20 years demonstrated an increased trend towards ACL reconstruction with 20-fold increase in 2017 as compared to 1997. And the study demonstrated that the risk of important complication after ACL reconstruction in pediatric patients is low, as well as the risk of growth disturbances after surgery. Another study demonstrated the low retear rates and good clinical outcomes after this surgery. However, the return to sports occurs later and is sometimes more difficult for the pediatric patients in the lower age group. This study presents some different results from the other studies. They found no differences between the transphyseal and physiosparing cohorts regarding the growth disturbances or graft survivorship. And as a take-home message, the current studies demonstrate that the growth disturbances and deformities after pediatric ACL reconstruction are rare if we take care during the surgical procedure. We should think about optimizing the surgical technique in order to reduce the risk of growth plate injury. And obviously, the current clinical studies demonstrate promising clinical results. Thank you very much.
Thank you, Stefan. And now let's continue with Gabriel Sterian and his presentation about lesion associated with ACL reconstruction delay in pediatric patients. Thank you, Stefan.
Okay. Hello again. So we're gonna have a talk about delayed ACL reconstructions and what delay means for these kids. I have no conflict of interest. So let's talk about the ACL tear. Okay, so the first thing, who gets it? Okay, so there is this tradition that kids don't get ACLs, but actually they do. They do have ACL tears, and this is something that we need to change from the start from our mindset. Okay, not every trauma to the knee, it's a sprain. Not every painful knee in a pediatric patient, it's are growing pains. Okay, and some causes for this pain can be joint instability. Okay, and as my colleague said, sport specialization, it's at an earlier age. You have professional tournaments all year round. They're more competitive. Complex sports are more accessible, like skiing now. Everyone's skiing now, so it's something only for the elites. Everyone can do it, and of course, the pathologies come after this evolution in the society. So things change in the society, and will also change for the patients. And how do we know? Of course, basic MRIs and clinical exams and history and talking to patients. Okay, and when do we know? And this is the biggest question. When do we know when you're thinking about delayed treatment? Because if the patient is not, included in a system like a sports academy or sports club, in which someone's actually taking care of them or sending them to the physician, sending them for the MRI examination, most of the kids come later down the line in the clinic. Okay, and we have this perception again that kids don't do this kind of pathologies. And again, there's another discussion with the radiologist, because access to an MRI can be quite cumbersome for some patients and for some individuals. And some centers don't do pediatric MRIs, they don't do only adults. So again, the way they diagnose, the time of diagnosis relevant to the time of the actual illness can be delayed. So if you have a delayed diagnosis, of course you're going to have a delayed treatment. Okay, these things go hand in hand. The strategy, of course, you have conservative, okay, surgical, and the surgical can be also early or delayed. Conservative, we go again to the first idea that kids don't get these things. If we diagnose them, then you have these options, okay? And conservative, from the literature and for our own experience, has the worst outcomes possible, because this thing that kids heal better, yeah, it's partially true, but we have to think about the anatomy of the ACL. So it's a double bundle. You can treat conservatively, but you have to consider what bundle, whether the patient has associated lesions at the time of diagnosis or later down the line. Okay, in surgical, again, early. My colleagues had a talk about treatment and surgery. Okay, and delayed. And having a delayed treatment, again, we come back to the conservative, in which we know that it's not good. And the reason for delayed surgical treatment, is based on the professional healthcare decision. Maybe they're not accustomed to certain procedures, certain techniques that are really good for pediatric, and they delayed the treatment until the biology and the physiology of the kids change, so they can do the techniques that they're accustomed and they're feeling comfortable with. And finally, the decision most of the times is not patient-driven, but it's parent-driven. So this can be a challenge on its own, and we have to get the compliance from the parents and also for the children. Conservative, okay, so you have like basic observation and you do nothing, just watch and see how things are going. Bracing and physiotherapy can be an alternative. Casting, I don't know who's doing it, but it can be something to consider for kids. And most of the biggest impact that you have when trying to do a conservative treatment and delaying surgical procedures is routine changes. So you're taking that kid out of sports. You're taking that kid out of social activities, and you get the kids stressed about it, and then they don't become compliant. So they remove the brace, or they just they wait for the parents to go to their jobs, and they're jumping on a trampoline with an ACL. So compliance and conservative treatment can be a big issue with that. And some of them even develop kinesiophobia because of that, because they know that if they move, they have that instability. If they move, they have some pain. So you end up doing a lot worse. And all these things are confirmed in the literature and all the studies that are done for this age group. Again, surgical delayed and early. And regarding the techniques, my colleagues presented some of them. So always you have to get the surgical technique based on age, sexual maturation, bone age, behavior, anatomy, other pathologies, and the goal. Again, what do you want to do with this kid? You want to have them the next Ronaldinho or Ibrahimovic? Or you just want to have a normal kid that's, sometimes he can run around the park and do like hiking, but not professional level. Okay, so we sometimes we do a decision based on that. And the surgical techniques, we have the over the top, the Michele-McIntosh technique. And these are the young kids, and as we go to the right of the picture, we go to the more adult-like patients with the complete transphyseal procedure. Graft choice, again, different topic. Some surgeons can be more accustomed or more familiar with some kind of procedure that implies a certain type of graft. Okay, and we have to always consider our technique based on the graft. So BTB and skeletally immature can be like an issue. A lot of growth plates in the tibia, in the patella. What happens with donor side morbidity if you're trying to do something like an adult procedure? So, okay, so we'll delay till we get to the point where we can do the BTB. Not good. Okay, we have a different option for that. The hamstrings, okay, is the mostly used graft for ACL reconstruction. But what happens if we do a periosteal stripping near the internal side of the insertion of the hamstrings? Okay, we do a complete epiphyseal structure, but they develop a genuvarum. That can happen because you have a periosteal stripping on the medial side of the proximal tibia. So this can be another comorbidity. So basically we're relying more on the ITB for really skeletally immature. And also graft choice, we have to think about congenital, because sometimes you might have an abnormal anatomy, and all of these things can go wrong, and especially the hamstrings can be really small and frail, so then you have to think about it different and have to adapt to get the graft choice right. Allografts, kind of out of the question, especially for kids that have the physis open, because as the bones grow, that allograft stretches, and all graft stretches, but allograft doesn't respond and have higher re-rupture rate for allografts than autografts. Okay, so let's talk about consequences for delayed. So we have some aspects here. So we'll start for the functional. If you delay surgical treatment, the first thing that those patients will be, complaining about is instability, and what that instability has an impact on the joint, on the usual healthcare of the patient. From chronic joint instability, even with bracing, even with physio, all of them say something about instability. Okay, then you have the anatomical. They go hand in hand. Okay, then you have meniscal tears, chondral lesion. You actually have a chronic joint pathology. Okay, and the threshold here are 3 months or 12 weeks. Okay, so every study said that every delayed treatment and every patient that had chronic joint instability, they developed irreparable meniscal lesions and irreparable chondral lesions after 3 months, which is kind of small period. You have a small gap to get these kids right. Then you have the social aspect. Okay, as I said before, you take them out of what they're like to do most, participate in sports, and most of them they go for fun. So if you're taking the fun out of their lives, they will be miserable. So you don't want to. And lastly, the costs. In the first place, it seems that it's cheaper to have a brace than an operation. It's cheaper to do physio than an operation. But on the long term, because you have all these things going on, the functional and anatomical damages, it actually gets a lot more expensive than to treat from the start. And we compare it with the early treatment. And what happens when you have an early treatment? The same things, the same principles. Functional, but they're better, but they don't have chronic instability. Not having chronic instability, they won't develop cartilage damage and meniscal damage. And again, socially, they will be a lot better because they get in sports a lot better. And the literature says that return to sports after an early ACL reconstruction, it's about 90%. When you do conservative treatment, on the other hand, people, few of them return to sports, but most of them don't return to sports at all. And the cost, again, cheaper than waiting for something bad to happen. So the take-home message is always do the procedure as soon as you can. You have this 12 weeks gap. Do regular MRIs, every 3 months if you go for the delaying protocol. See how the biology changes, see how the patient is going forward. And if you're not comfortable with a certain technique for pediatrics, it's better for the patients to refer them to someone that has more experience rather than stick with the patient and wait for the door to open for you to do that procedure that you're feeling comfortable with.
Thank you, Gabriel. And go on with Nicolas Brebond from Grenoble, France. He will talk about arthroscopic meniscal treatment in pediatric patients. Thank you, Nick.
Thank you, Marco. Good morning, everybody. Thank you for your invitation. So I'm speaking about meniscal injury and arthroscopic in pediatric population. Of course, I have no conflict of interest related for this presentation. So, generality, meniscus were originally considered vestigial, easier to resect than to repair, but it's important to repair. Past decade, the importance of meniscus investigated and understood, and following meniscectomy, cartilage overload, and aggravated degeneration. About the anatomy, vascularized portion is important for the security of the treatment. And there is 3 zones, red, white, white. And when we are in the red zone, it's good for the suture and for have a good cicatrization. A little biomechanical analysis. The meniscus is important for load transfers, shock absorption, stress reduction, the stabilization, and the lubrification. Two questions. When I take, when I have a meniscal injury, it's a discoid or is not a discoid menisc, and if it's not a discoid menisc, the knee is stable or not, so there is ACL tear or not. So we speak about meniscus discoid anatomy. The meniscus discoid is a meniscocongenital deformity with the compartment externe is the compartment of the mobility, and during the flexion you have a move, anterior move, and during the extension you have a posterior move. It's important for understand after. A little embryology. No discoid embryologic no, just the picture. It's 7 months intra-uterine during the pregnant. And the anatomy meniscus is same like me. Okay, so it's crazy. For lateral discoid, there is no genetic role, a minor role. Some case report. It's a congenital deformity, and the incidence is a good variability because in European is more 5% and Asian is more 16%. We use the classification of Watanabe with 3 types. The type 1 is complete, the type 2 is incomplete, and the type 3 is incomplete with no posterior attachment, only with Berg ligament for the posterior attachment. How we do the diagnosis of discoid meniscus? Often asymptomatic, so it's difficult, but there is sometimes pain and snapping knee. With the X-ray, you can have a winding of lateral joint space and squaring of lateral condyle. Sorry. We use the MRI. We have a classification with the thickness on the surface, and it's important to have this imagery. The natural history of discoid meniscus is prone to tears. Type of tears depend upon discoid tip. Type 1 more horizontal tears, type 2 more radial and complex, and often associated with osteochondrite of lateral condyle. For the treatment, for the asymptomatic, leave it alone, very important. Don't not make an intervention with patient asymptomatic. And for the asymptomatic strategy, in the first one, reshape to normal, meniscoplasty or socialization, like this. We do the socialization for have a normal anatomy after, normal. And in second time, repair of remaining peripheral tear, the instability, like this, posterior instability. And depend of the tip with unclassification, we have three types, A, B, C. For the A, it's a meniscocapsular junction anterior on with instability anterior. And for the B, it's a meniscocapsular junction posterior, so posterior instability. And for the C is a posterior, but there is meniscus again with popliteus region. So for the one, so the A, we know that in extension you have a move in posterior of the compartment externe, lateral. So when you are in extension with the A, you are a migration in posterior of this menisc. And you can do the diagnostic with your classification, and you know what happened after, what is your strategy for the future, for your treatment. On this, you can't choose your strategy. You can only say it's a discoid, okay? But with the sagittal, you can choose when it's like this. An example of meniscoplasty on anterior repair out in. Can we put the video? Okay, so we do the meniscoplasty. Be carefully to not be you have to be economic for the meniscoplasty. We use a shaver for the healing, the vascularization, stimulate the vascularization also. And you have the condyles on the meniscus here, okay, for the neuro-orthopedist. And we are on the posterior compartment, it's the anterior compartment here. Okay, we do the suture and out in. Okay. For the B and C, it's a posterior instability, so you have to make a suture in posterior, and the displacement is anterior in extension, like this. Okay. We are testing the instability of the posterior corner because sometimes it's not an evidence, and you have to show with your palpator for trait after the tear. Can you put the? No. Okay. And you have the mobility with the vascular, with blood, and it's okay for suture. Here you have a horizontal tear with a discoid, and you have to do a vertical suture after saucerization, like this. Okay. And what happened about non-discoid meniscus injury? You have a lot of tears, simple longitudinal, double longitudinal, flap, radial, and complex patterns, and bucket handle. Why repair? Because we have to restore the function, maintain load transmission, and minimize contact stress, restore secondary restraint for stability, and it's a chondro protection, of course. Indication of repair: acute tear, peripheral tear, red and red-white zone, unstable tear length more one of meniscus, subluxate under the condyle, stable knee profile. But also consider reparability, healing potential, very important, associated surgery, and patient preference too. I'm so long. Right? Vertical tear on this picture. Okay, you can see with a big, good vascularization, so it's good for the suture. And you can see on the ERM the grade 3 of this lesion, and we see on the arthroscopy. An example in pediatric too, with horizontal tear, you can have communication with capsular, extracapsular, with a kyst, and you have to do an artroarticular treatment with suture, and go to the kyst, and maybe you have to do a second incision in lateral for evacuation of the kyst. Okay. A little study about non-discoid meniscus injury, multicentric prospective series symposium soft cut. So a lot of meniscal tear, the age 14. And it's interesting to note there is not a lot ACL tear in the population, and time to chirurgy is 11 months. And it will be good to have less than 11 months, but it is the wear actually for this. The combat, the king, coupé. The symptoms: the pain, locking, swelling, snapping, giving way. And for the clinical examination, you have the effusion, restricted knee extension, bucket handle, And for the test, it's not very important.
We have to finish, Nico.
Okay, I finish. And just the last one, classification to show. Okay. Thank you.
Okay, thank you to everybody. Sorry, but we don't have the time for discussion because we have no time, but pediatric arthroscopy is